So let me just say a word about our first presenter, and that's David Keller. And David is a fascinating guy, a researcher, an author. He's written about 8 different books, PhD. I just met him a few months ago, but I've just found him to be a fascinating person and very thorough in his research. So with that, I don't want to spend too much time, Dave, in introducing yourself. They'll get to know you and what you share. So Dave, you're on.
Thank you, Mark. As I put together my screen share here, let me say that I'm honored to be with you, and that I'd like to do a shout out. My sister Susan is watching from South Carolina. Hi, Susan. Also want to say that I am a PhD in East-West psychology. I'm not a medical doctor. Everything I say is based on my personal experience and research. I am working on my 9th book on prostate cancer, hopefully in collaboration with the medical writing superstar and Pulitzer nominee Howard Walensky, if he will. And if any of you have anything that you would like to contribute to this manuscript, please write me. My email will be on the bottom of every slide. I would like to start by saying that it's been, probably like many of you, an emotional and informational roller coaster ride in this whole process. In 2016, a chair of a urology department said, "Oh, your PSA is 5.7, so you have to have 19 cores taken out of your prostate." And I said, hang on a second, let me do a little research here. I researched and found out that my PSA density was only 0.09, which means there's a 96% probability that I have a very healthy prostate. So I politely declined, and I found a urologist that would support me in active surveillance. But the PSA went up 7.6. Urologist did an MPMRI, saw a tumor, got biopsies done, and the hospital pathology department said, "Whoops, you've got 3 Gleason 3+4 Gleason 7s," and all the urologists are saying, "We're gonna have to take out your prostate, radical prostatectomy." And on January 15th at 3:15 p.m. of this year, the chair of Mayo Clinic said, "You have to have a radical prostatectomy." My wife and I agreed, regretfully. And then 15 minutes later, the 5th urologist that I consulted got back to me, Eric Klein, Cleveland Clinic. They did their own pathology report on the tissue, came back and said, "No, you don't have any 3+4s. You're just all 3+3s. So you're Gleason 6. You can be on active surveillance." Yippee. Wow. Holy cow. What a difference 15 minutes makes. Talk about that roller coaster ride. Okay. Then Cleveland Clinic did a deciphered genomic marker on me, came back, high risk. Uh-oh. Sorry, Dave. You have to have your prostate out. We have one of the top radical prostatectomy surgeons here if you want to use them. So I thought, well, let me get a second opinion. So I went to Oncotype, got another genomic marker test. Guess what? Low risk. Low risk. So I thought, well, let's do a tiebreaker. I went and got a 3rd genomic marker test, okay? And that came in at right on the cusp of active surveillance. So guess what, folks? I'm in active surveillance, even though twice in this process, I had made the decision that I had to have my prostate taken out. I am back to active surveillance. And so I wanted to tell you that before you do a biopsy, during the biopsy decision process, and after biopsy, there's a number of things you should do. And the first 3 numbers that you really need are your PSA number, of course, your prostate volume, and it's absolutely essential that you know what your PSA density is. There are more than 2 studies that say that the PSA density number, which is your PSA divided by your prostate volume, is far more predictive of your prostate health than PSA alone. So you've got to know what your PSA density number is. As you all probably know, your PSA can increase from things other than cancer. It can increase from prostatitis, an enlarged prostate. I took antibiotics, my prostate PSA number went down 1 whole point. There's a lot of tests that you can take, urine and blood tests, and the gold standard though right now is still the MP-MRI. I had a 7.6 PSA, so they said, okay, you got to have the MP-MRI, came back pyrates 4, and you want to know that you should do all of these things before you really make a final biopsy decision. The biopsy decision for me was made together with my urologist. But then there's a whole nother series of things you need to know. There's a transrectal biopsy, a transperineal biopsy. There's targeted biopsies, there's saturation biopsies. There's the ultrasound supported approach. There's the fusion approach where they use the MRI and the ultrasound. When you compare transrectal to transperineal, you should know that transrectal is commonly referred to as transfecal, because you can see from this bottom of this slide, the transfecal needle goes through your rectum, through potentially fecal matter and into your prostate, potentially introducing fecal matter inside your body. You can get sepsis, end up in an extended hospital stay, or death. One of the urologists that I interviewed lost a patient following a transfecal needle biopsy. The second approach is transperineal. It comes in at a different angle through the taint area of your body, the part between the anus and the scrotum, and it has a much better access to certain parts of your prostate than the transfecal approach. Another thing that you should know, that even though transperineal doesn't go through fecal matter, statistics show, studies show that the more cores you have taken under the transperineal approach, the greater your risk of the dreaded AUR. What's AUR? Acute urinary retention. Okay, this is when you want to pee, you feel the strong urge to pee, and you cannot pee. And that pressure is building. I have to tell you, I went through this twice following my transperineal saturation cores. They took 57 cores out of my prostate, if you can believe it. I had agreed on 36, but they ended up taking 57. And I had to go to the emergency room twice via ambulance because I experienced acute urinary retention. It is hell. It's like kidney stone in your penis. You don't want to have it. And it could be causing damage. The longer that's happening, your bladder wall could be deteriorating and urine can be going back up your ureter into your kidneys. It's a problem you need to know about and make sure you avoid. One of the things that happens in transperineal is you will generally go home with the catheter for 1 to 7 days. Typically in transrectal, not so much. Another thing you want to know about, and this is really important, how is your doctor going to approach the biopsy? Are they going to just use the old-fashioned way of just ultrasound, like they did with me? Or are they going to use the modern technique of a fusion biopsy where they use a machine like this, the UroNav, that has an algorithm that combines the MRI imagery with your ultrasound imagery so they get a much more accurate view of your prostate while introducing the needles into the prostate. And so with that, I'd like to say that there's a lot that needs to be done after a biopsy, but I want to turn it over to Q&A now and just finish with this, that when a doctor tells you you need an invasive procedure, you should become a colleague of that doctor. You should put on your doctor of research hat and say, doctor, I know you're one of the best in your area, but if you were to have this procedure for yourself, who would you use? Ask that question. They expect it, they have an answer, and they will respect you for asking it because it's one of the most important logical questions that should be asked at that point in time. And with that, I'll turn it over to Mark.
That's excellent. And that last piece of advice about asking the doctor who he would go to, I really like that. And that brings to mind a question too, which I was initially a little bit intimidated about, because you want to get a second opinion were you ever in a situation where you said to your doctor, listen, I'm feeling like I want to get a second opinion, but maybe were reluctant to say that in order not to offend the doctor? Did that ever occur with you?
Yes, I was raised a good Catholic altar boy, and I'm a 2 on the Enneagram, so I want to please people. I don't want to upset anybody.
Right.
So that's not a good approach to your medical life. You really need to ask a lot of questions. You need to have a lot of strong self-esteem. I won't say in this group, I will say it. You need to have the balls to have the courage to ask those questions that you really need to ask in order to pursue. You can't let the fear of hurting your doctor's feelings. Believe me, you can't hurt their feelings. They've been through a lot. They face death. I mean, I've interviewed 5 urologists. One of them lost a patient doing biopsy. So they've had a lot tougher questions than you could possibly ask them. So get them out there. Don't be shy.
Excellent. So on that, related to that, was there a situation where you really felt like you wished you had stood up for yourself better? And how would you play that if you redid it? How would you do it now?
That's a tough one for me because that happened to me. I did a lot of research. I had an opportunity to have an updated MRI done at Mayo Clinic and have them do the biopsies. But they weren't going to be able to do it for a few weeks, and it was going to, quote unquote, interfere with a vacation calendar that was the family had planned on, actually just a visitation to some family out of state. And so I went a different route. I went with a doctor that I consulted with. He was one of my primary urologists. But it wasn't based on the best research that I had. It was based on timing. And unfortunately, I suffered rather considerably because of that miscalculation. Don't let family, spouse, partners, calendars interfere with what you know in your gut is the best thing to do. As Mark says, you need to rely on your own informed scientific intuition. And I didn't do that for a moment. And I suffered 14 hours of acute urinary retention as a result, probably. All I want to say to you all is make sure that the first, second, and third priority for making your decisions is your health and nothing else.
Well, that's an important message. And we've received that from many men who have had intervention, Gleason 6, low risk, and they've had intervention and they've been miserable. I mean, your story is a cautionary tale, but there's many that have not been willing to stand up for themselves and have had a great deal of regret. So that is an important message. By the way, for those of you that are wanting to enter things into the chat room, I just wanted to be sure. Sometimes people are confused about this. You got to get to the everyone, because it's going to go to everyone. The question is going to go to everyone. And then you have to enter your whatever you're going to ask and then hit return. So was there anything funny that happened along the way that you can think of? Any humorous incident? I know
Yes.
I'm blindsiding you on that one a little bit.
No, it's true. It is humorous. When I called 911, they expect a gunshot wound or something. And I was on the 7th floor of my condo. And I knew this was my second visit. They'd already taken me once to the hospital. And then literally about 7 or 8 days later, I'm calling them again because I couldn't pee. I'm in extreme pain. And I knew that my bladder was being damaged. And, but it's just funny that when I not only greeted them at the front door in the lobby, I walked out to the ambulance because I wanted them to hurry to get me to this was late at night after hours. I certainly couldn't drive. My wife has glaucoma. She couldn't drive at night. And so I needed that ambulance to get me there. And I was saying, come on, guys, I know I don't I look okay from the outside, but I am being damaged every second on the inside. So I had to do a little negotiation to get some rapport with the 911 ambulance techs to feel okay about using their valuable time to take me to the hospital.
Sure. So with your MRIs, was contrast offered?
Yes. And I even asked him about this gadolinium. I said, what's that? And it's, oh, don't worry about it. You'll peer it out shortly after within hours, no problem. So since then, I do have a concern about gadolinium, and I will try and get the next MRI done without it. I will negotiate that.
That's good, and it's fully negotiable. Today, we found amongst us in ASPI that there's many opportunities to eliminate the gadolinium, and if you still want contrast, there's lesser harmful, less harmful contrast. Okay, you know what? I'm realizing that I'm taking up a little bit more time on this than I should, but I want to I want to ask one or two questions that's in here. By the way, Dave, you had asked about Dave Maraj. You'd asked about a Gleason 9. So are you on active surveillance, or can I do active surveillance? Whether we've had treatment or chose not to have treatment, we're all on active surveillance, actually. It's just a question of the degree of your active surveillance. And after you have treatment, there might be a little bit more weight with the active surveillance. We can talk about that later if we have time. So the first question here, with regard to the 3T MRI, the quality of the machine, expertise of the person reading. In a series of MRIs for tracking, is it better to use the same machine / reader or use a different provider each time? Do you have an opinion on that, Dave, or not?
I do. I think you should get a second opinion on everything that if it's involving an invasive procedure, so yes, I think, in fact, that's why Mayo would not accept the MRI that an outside company did. They will only use their own internal MRIs so I think it's a good decision to get backup of every key test.
Thank you, Dave.
And you should know that research shows that, MRIs are not perfect, we all know. And studies show that anywhere from 2% to 25%, it can be an error. And I learned two new words. One is an unimportant tumor. I didn't know those existed. And Howard knows this term, an artifact. You could, something could show up as an artifact that's may look to an amateur as a problem, but it's not.
Okay, well, let me ask you one more quick question because this came up with a couple of people. So the TP apparently requires a catheter. The transrectal generally doesn't require a catheter. Do you have any idea why the TP requires a catheter?
I can only tell from personal experience. When you invade the prostate, it'll swell. And when it swells, it squeezes that part of the urethra. The urethra passes from your bladder through the prostate into your penis. And if this is one of the reasons why men, as they get older, in some cases, the prostate gets bigger and it squeezes on that urethra. And so it's harder to get the urine out. And after biopsies, it can be so swollen that it shuts it down. So that's why they stick an artificial tube up through the urethra and into your bladder so that the urine can come out of the bladder through your penis. And depending upon the amount of swelling, they think that with transperineal, apparently there's a lot more swelling. That's why you walk away with a catheter, usually 1 to 7 days. Obviously, my swelling came back after they took the catheter out. They had to recatheterize me a second time. And then when they took that out, the swelling came back and I had to be recatheterized a third time. And then I self-catheterized myself for a week just to be on the safe side because the pain is so great through acute urinary retention. So I willingly taught myself and got assistance in teaching myself how to self-catheterize to avoid that pain. So it's just a degree of swelling. That's the difference between catheter and no catheter.
Okay, well, thanks again, Dave. So we can move along. I'd like to introduce Phil Siegel, and he's going to introduce the next panelist. And Phil is a fellow AS patient from Canada, and so we welcome our Canadian brother. Phil, you're on.
Thanks very much, Mark. Just a little bit of background on myself. I've been on active surveillance since 2007, so I'm just about 14 years on active surveillance. I've done a number of biopsies, the last one being a transperineal, and fortunately, unlike David, I had no issues with it at all. It was smooth sailing. In any case, that's my personal experience. I'd like to introduce our next speaker, who's also from Canada. His name is from Ontario, but has lived for the past 25 years just outside Vancouver, British Columbia. Dale is 66 years old and tells me that he's scheduled to retire this coming Tuesday. However, this is his fourth attempt at retirement, but he thinks that this time it may stick. Dale has an MA in political science and a diploma in public administration. He's worked for 25 years as an investigator and as a manager of investigations for 2 provincial ombudsman offices in Canada. For the past 10 years, he has been an arbitrator and mediator and has managed an arbitration team for the province of British Columbia. Dale has also managed his local member of parliament's office during his work career. So now, knowing a little bit about Dale, let me present him, and he'll talk about his time on active surveillance, as well as the factors that led him to leave active surveillance and have a robotic prostatectomy in May 2018. So Dale, the floor is yours.
Thanks, Phil. My story starts early in 2013 when my family doctor noticed that something a bit suspicious in a digital rectal examination. When I told him about my frequent need to urinate, especially during the night, he thought it was time for me to see a local urologist. Now, I have to admit that I was a little suspicious about this fellow when I looked up at his specialist certificate on the wall and noticed that the date on there was written in Roman numerals. This was a really old urologist in a bit of a pop-up operation. However, I continued to see him for about 3 years, obtaining regular PSA tests and prescriptions for Flomax for my BPH issue that I was having, the moderately enlarged prostate. By June 2016, I had that disturbing conversation that I think pretty well everyone here has had, where the urologist tells you that you've got prostate cancer, and told me that it was after a random biopsy had been performed, a transrectal one, which showed that I had a problem. I had Gleason 6 cancer with, it was 3+3, and 2 of the 10 core samples were showing evidence of cancer. So like most of you, I chose to go on active surveillance. This seemed like a natural extension from the previous 3 years that I'd been seeing this urologist. I fully expected to stay on active surveillance until the specialists recommended more active treatment. Even though my PSA never really exceeded 7.5 and I never had anything more than Gleason 6, I eventually changed my mind and had a radical prostatectomy, a robotic prostatectomy in 2018. Now, something in the order of half of the people that are on active surveillance eventually choose some type of more active treatment. And for that reason, I've agreed to speak with you today about the factors that I took into account in making my decision to have more active treatment. Now, my first and most important takeaway, and probably the only thing that you need to remember from this, I'll leave you with, is everyone's cancer is different. And as is the case with snowflakes and fingerprints, no diagnosis of prostate cancer is quite the same. Everyone's decision on how best to manage their cancer and their health is also unique to their own circumstances. And you'll receive lots of advice from healthcare specialists, family, friends, and others who have been diagnosed with prostate cancer. Some of this will be requested, and some of it will be offered up to you without being requested. At the end of the day, the decision's yours, and yours alone to make. And there's nothing etched in stone that limits you from changing your mind on how best you can to proceed as you get more information. I suspect I'm not the only one on the call here today whose first inclination was that they would wait the process out. This makes sense. By waiting, you can obtain active treatment when you need it at a time when medical research has developed to the point where you can consider better, less severe options. Waiting to let better techniques of treatment develop had worked well for me in avoiding knee replacement surgery. Doctors have been telling me since I was in my 20s that I would have to have knee replacement surgery, and that their hope was that I could put it off until I was age 60 so I wouldn't have to end up having 3 knee replacements. Well, I'm now 66. I still haven't had a single knee replacement yet. I've had 7 knee operations, but no ACLs, no knee replacement surgery yet. So this history of relying on, of delaying decisions has stood me in good stead over the years with the knee issue. So this made me a little more receptive to the active surveillance philosophy from the outset. As it turned out, I was really only on AS for about 2 years. And the true gift that it gave me over that time was that it gave me time. And time to use my investigative skills to sort out this new and perplexing diagnosis, and with all the acronyms that go with it. You need time to obtain additional information from healthcare professionals. I ended up getting, listening to David, I ended up getting 7 different second opinions, we'll call them, over time. Gave me time to sort out how I and others felt about this and how I would come to terms with the diagnosis. So you'd probably ask, how did I make use of the time afforded to me by being on AS? One is to seek out second opinions, and as many as you need over time to make to help you make your decisions. More importantly, perhaps, don't limit these second opinions to options that you're already predisposed to choosing. You can't shop around for the right answer and say, aha, I've got the best answer. Listen to everybody. Now that having been said, hear what they all have to say, but keep in mind that surgeons are paid to cut and radiologists, radiation oncologists are paid to radiate. So you have to keep in mind that they're going to have their own biases from the start too. Suggest that you find out about programs and sources of education and support that can make you feel less isolated and dependent upon your healthcare specialist for information. I made extensive use of the prostate cancer support care program at Vancouver General Hospital. From one-off introductory sessions during which a urologist and an oncologist consult with you privately for 15 minutes at the end of the session, which is great, to programs on pelvic floor physio for incontinency, sexual function, diet, exercise. They even offer personal counseling. I felt like I was in a protective cocoon once I entered this program and this process, as opposed to a one-person operation, the original oncologist that I saw. I also attended conferences. I attended the Pacific Northwest Prostate Cancer each fall that was co-hosted by Vancouver General Hospital. And all the people here are doing much the same, attending conferences. Find out as much as you can about this because the time is really useful. So what did I find out that changed my mind? Well, in short, I found out lots. I had to piece together what seemed like random information, though, to make sense of it all. And that's probably something all of you are going to have to do as well. After first being diagnosed, with one exception, my PSA continued to steady increase up to about 7.5 by the end. Given the rate of increase, I likely reckon that I had about 2 to 2.5 years before I'd have to take some kind of more active treatment. I had a biopsy, another one. This was the random sample transrectal biopsy I had originally showed cancer in 2 of the 10 core samples. I had a second one in 2017. And this one was I first had an MRI and it was targeted. And the MRI showed that there was a very high confidence level that I had PIRADS 5, that there was a cancerous lesion in the left apex transition zone. The subsequent targeted biopsy confirmed Gleason 6 in the left apex, but they found considerably more and larger group of abnormal cells in the right apex. They also noted in the MRI that there was multiple BIRADS2 nodules in the transition zone. So this was good news in one way, and that it was still Gleason 6, and that was great. But the bad news was that it was pretty close to the perimeter of the prostate as opposed to being buried deep within the prostate. The Flomax, another factor was the Flomax I'd been taking for 4 or 5 years for my urinary issues was no longer really helping that much. And I couldn't sleep more than a couple of hours a night at a time, and more nights I'd be up every hour, hour and a half, something like that. So it's not great to never get a good night's sleep, and that doesn't help you long term. I also have some family history I had to weigh into this. My father had an enlarged prostate and BPH for a number of years. And my brother died before he was 65 with bone cancer. And we're uncertain where that started from, but we're suspicious it might have started in the prostate because he never saw a doctor until he was finally sick at the end. Another factor we talked about a little earlier, I didn't want to keep getting biopsies all the time. There's risk of infections. Every time they go in, there's a risk of infection. And the issue of, as David phrases it, a transfecal biopsy is not something I wanted to keep doing. Now, by this time, by early 2018, after I'd had my second biopsy, I'd learned enough to know that the option that I wanted to take if I did eventually need more active treatment was robotic prostatectomy. And this would address both my BPH issues and the prostate cancer issues. They could always radiate or give me ADT afterwards after the surgery if necessary. And the advantage of robotic surgery is that it provides for a much quicker recovery time and a lot less potential problems there. So I consider myself very fortunate by that time to have been referred to one of the top urologists in my province. He was one of 2 surgeons in the province who were conducting robotic surgery. He was doing most of them actually at that point, and he did all of his surgeries that way. So when I first saw him at VGH, he recommended that I also see an oncologist, as he said that the success rate that he was having with radical prostatectomy was similar to what people were getting from brachytherapy. He described them as 1A and 1B options. So I was encouraged. He was still recommending that I stay on active surveillance, but he also realized that the location of the cancer was as much of the issue as anything else. So I was still in excellent health at that point and was a good candidate for successful surgery. I was also planning to retire soon for my first time or my second time, I can't remember which, and travel a lot more. And getting this out of the way with a top urologist who was trained in that area of robotic surgery would enable me to get to make my retirement plans a little more concretely and without having to worry about coming back for tests and does that interfere with my schedule with my urologist. But before I made a final decision, I went back to the prostate program, again, the supportive care program, and decided to go see the introductory session again. So that was a year and something after I'd been there originally, but I wanted to see an oncologist and a urologist, somebody different again, to get this 15-minute consultation. And I asked them whether there was anything on the horizon that was going to help me within two to 2.5 years that would be a game-changing sort of breakthrough that would give me better options than going for a radical prostatectomy. And both of them advised me at that time that it would be probably 5 to 10 years before they would have that kind of breakthrough technology in place in this province, at least. And as it turns out, they were probably close to being right with that. So the other factor that I looked at too was my doctor. He's an author. They hand out the book that he wrote to everybody in the province. He was with prostate cancer. He's teaching. He takes sabbaticals for teaching as well. He's an expert. I could figure by his age that he'd likely be retiring within the next couple of years. And if I waited 2.5 years, I'd probably end up with a different urologist doing this. I likely wouldn't get robotic surgery, or if I did, I wouldn't get the same person at all. So I factored this all in and said he'd likely be retiring. As it turns out, I had my surgery in May 2018. He saw me once after that, and after that, he had stopped seeing patients. So I was right with that it was time sensitive to a certain extent. So after learning how close to the surface of my prostate the abnormal cells were located, I decided that delaying till later ran the risk of allowing the cancer to get outside the prostate. I had an opportunity for robotic surgery with a top urologist, and I thought that that was the time to do it. So I had an excellent result with my surgery, with no reason to believe that the cancer has spread. Better still, I only wake up once a night, usually sometimes twice a night. I get a good night's sleep usually now. My urine flow, my bladder control is much better than it was. My final takeaway then is that with AS, it gives you time, and time that you're lucky to have, because I talked to a lot of fellows in my own local prostate group who didn't have that kind of time. They had to make an uninformed decision without much time to do so. So I suggest to you fellows, use your time wisely, fellows. Weigh all the factors that are important to you and for you. And as you take in more information, continuously reevaluate where you're at and whether the new information you've received and how you feel about your previous decision still makes sense for you. What was right for you back when you originally made the decision to go on AS may not still be the right decision for you. So you have to consider all your options, as things are going to change over time as you learn more. The new information may reinforce your previous decision, and it may change them. But don't get so stuck with the commitment that you've made to your earlier choices that you're unwilling to recognize or accept a changed set of circumstances. So that's basically what's happened with me, and I really encourage you to make use of the time that you've got. You're doing some of that by attending this conference here today. Thanks, fellows.
Thanks very much, Dale. That was a great presentation. I think what you said and your talk as well as David's talk is just really reinforced the importance of getting a second opinion, and the importance of really being your own advocate, doing your own research to really find out what's best for you. Mark, I don't know whether we have that many questions in the chat at this time. So,
Well, Phil, how's your stand-up routine then?
Nowhere close to yours, unfortunately.
Well, what do we see here? Well, we'll just move on then, and people can raise their hand at the end in any event if we miss their questions. So yeah, why don't we just
Sure.
move on to Howard. Hey, by the way, Howard, I'd like you've been so helpful in terms of Howard's working on a book too on prostate cancer, and so he's been interviewing a host of people about this subject, and also has been helpful in making these town halls possible. We have another one coming up on April 24th at the same time. Howard, do you want to talk a little bit before you introduce the next speaker about that? Thank you.
It's going to be April 24th, same time, same station, different cast of speakers. And it's going to be a very special meeting because I don't know if everybody, I think people probably have already detected it from today's meeting, which is there's a revolution that's unfolding in care of men like us. Specifically, there's likely to be a major transition from transrectal biopsies to transperineal. And in fact, in Europe, in January, the European Urological Association has recommended transperineal procedures as the #1 approach. And this is something that's going to be debated by the American Urologic Association later this year. And you're going to be if you follow this, you're going to be hearing a lot more about it. And so we're going to have a panel on April 24th that's going to include actually one of the early participants in Aspi, which I co-founded with Mark and Throwen and Gene Slattery. And that's going to be Dr. Ferd Becker, who is not only a doctor, but is also a man on active surveillance who nearly died from sepsis from a biopsy performed by one of his colleagues. We're going to have Rick Popard, who is a British doctor who calls himself a prostatologist. And I see Eric had mentioned the Trexit 2020 proposal, and Rick Popard's one of the authors of that. And the idea is to leave this old technique behind by 2022. And then we're going to have Matt Alloway, the inventor of the precision point procedure, which is revolutionizing the field. And by the way, you know, I question David on whether the problem he had with the catheter might be the result of undergoing the old technique. And we're going to have a nurse from Britain who does these procedures, and also possibly a leader from Norway, because Norway changed their policy overnight because a single man died from sepsis. But at any rate, that's that program. Let's get back to this program. I'm introducing my friend Joe Gallo. And when I say friend, I mean it. Joe and I have worked together closely on meetings like this for the past year and a half. Joe is a veteran of IT work, but he also is a Marine Corps veteran. He was a captain in the US Marine Corps, but apparently did not learn the major lesson for the military teaches you don't volunteer. Joe can't help himself. He's a compulsive volunteer. So he volunteers with this group. He volunteers with ANCAN and us too. He volunteers with Zero. And he just was named to serve on a committee at University of Maryland for a major study that's underway. And I'll give my wife a plug. She's also on that committee. Meanwhile, enough about Joe. Let me turn it over to Joe.
Thanks for the intro, Howard. What a buildup.
I hope you don't let us down, dude.
Well, you used a couple of my lines, but I'll do them anyway. I'm probably a little bit from an age perspective on the older side. From an active surveillance perspective, I'm on the younger side. I've only been on active surveillance now since diagnosed a little over 3.5 years ago. So I don't have quite the experience that a lot of the other fellows that you've heard so far. I think, as I indicated earlier, I live on the East Coast, near Philadelphia, Pennsylvania, on the East Coast of the United States. As Howard said, I'm a retired IT director, and I did do my time in the Marine Corps, including an experience in Vietnam and during 1969 and 70. And that's where at least it's been perceived that was the initiator to via Agent Orange for my prostate cancer, as well as a couple other things, a couple other heart ailments. So I am on technically disability through the VA. I get my medical support both commercially through private hospitals and as well as through the VA. And in case of my treatment for prostate cancer, I am predominantly dealing with 2 outside hospitals, including Fox Chase in Philadelphia. I'm not going to give you a lengthy background bio. If you have anything that you do want me to extend on, definitely put it in the questions and we can pick it up. My diagnosis, as I said, was back in 2017. It was initially, the visit was based on the fact that I had a PSA of elevated, and so the doctor that I met with and I'll give him a lot of cred. I asked him, I said, you know, what's your primary motive? What drives you? How do you get compensated? Because I wanted to know where he was coming from. I knew he was a surgeon. I wanted to make sure that he wasn't going to be talking to me about surgery. And he indicated to me that being the head of the practice where he was, he got paid a salary. And so his objective was to do whatever was best for me, not necessarily what would be best for him or the hospital. That was a good start. And I think that's one of the things you do need to consider. You'll hear it multiple times from multiple people. When you're talking to someone, when you're talking to the surgeon, he tends to feel surgery. When you're talking to the radiation oncologist, well, he looks at radiation and so forth. In any case, I actually led him into doing a biopsy. I wanted to know where I stood. That's my natural tendency. It turned out I had 3 cores. Actually, he wanted to even call it 2 cores that were identified because one was less than 2%. Gleason 6. And so I said, fine, that's good. Where do we go from here? He said, well, we can, you know, put you on active surveillance and monitor it for a while. And again, you know, I think I did the initiative more than he did. I said, okay, but how about an MP-MRI? He said, well, we can do it. That will give us an indication as to where we are. And realizing that the standard biopsy is just that. It is a statistical random, and it may or may not hit you know, all spots within, well, it won't hit all spots within the prostate. I had an MP-MRI done and came up with a PIREDS 2. PIREDS 2 indicates that, you know, there's nothing that was totally discernible. With that, again, now this is at my urologist instigation. We sent the slides off to the Oncotype DX genomic testing, and that's part of what we're going to talk about in a couple of minutes here. And I'll point out the results back here in just a couple of minutes. So I had the genomic testing done, and followed with that, I did what you've heard presented here earlier as well. I went off and said, okay, I want a second opinion. I want to take all these results and I want to go somewhere outside of your practice. And I went down to the University of Pennsylvania, which, you know, they've got pretty good cred as well, and met with them, met with the head of the urology department down there. He reviewed all of the results and confirmed what we saw: low volume, Gleason 6, low indication. And I said, fine, that's good. That makes me comfortable, because I want to be comfortable if I'm going to do active surveillance. The genomic tests, you'll hear reference to genomic and you'll hear reference to genetic testing. They are different, even though their terms tend to be used interchangeably. The genomic test, the Oncotype DX example, is also known as Genomic, and it looks at the tissues that were retrieved in the biopsy. It's an analysis of the actual material within you. What they do is they run that up against a database, and they do a statistical analysis to do things like project the aggressiveness and the potential for metastasis. That's different than genetic testing. And you'll hear reference to genetic testing in some of the discussions. The genetic testing is also called germline testing, and that looks at inherited mutations or characteristics. That's where it came down through the family. That's typically used, it's now very highly recommended for those who have potential advanced stage prostate cancer. But what they're looking at is specifically looking for BRCA2 and BRCA1, BRCA mutations. BRCA, as many of you know, is related to breast cancer. Well, it also impacts prostate cancer. And those types of things are necessary between the genetic and the genomic testing are what you can use to work with your doctor to try to determine when, if, and how you would be treated. In the genetic test, they look for the BRCA. In my case, they found only one mutation, and it was an HOXB13. Wow, good term. HOXB13 is associated with prostate cancer, but they have nothing further to say about it. There is a lot of study going on, but they just know it's associated, and they know that it doesn't seem to have any immediate impact. After that, 1 year after my initial biopsy, I had the confirmatory biopsy, which was pretty much in line with the NCCN guidelines. Again, the results came back Gleason 6, 2+ cores, okay? And so what we did with those results is I had another MPM RI done. Again, came back with a PIRADS 2 evaluation. And we sent those results off for a second different genomic test for Prolaris. The three most common in the US, most prominent ones are Oncotype DX, Prolaris, and Decipher. Decipher is also used extensively in post-radical prostatectomy analysis, whereas Oncotype DX is aiming at low and up to intermediate favorable prostate cancer. All right. What I'm going to tell you after that is that I've just recently, to continue my active participation in active surveillance, is I've just recently had a micro ultrasound evaluation done with the Exact View device. That's a real-time visual. It's not quite the same as an MRI, but it does give you an actual real-time look at the images of your prostate, and it does cover the extent of it. I've seen the physical output because I was there and watched it at the same time. I do not have the report, so one of our future sessions, I'll be able to give you more information on it, except that we were able to discern a lesion which needs more analysis. I've also had a liquid biomarker done, the Select MDX. And again, it's one of those things, when you send it off to the lab, you have to sit still for about 2 weeks waiting for the results to come back. And that pretty much wraps up my current situation.
Okay, so I guess I dive back in, right? So Joe, I think you probably were speaking a foreign language other than English as far as a lot of the attendees, because they're from Europe or from Canada. And I don't know if you are the right one to ask about this, but in those countries, as I understand it, especially genomic testing is rare. And I wonder if you can explain, or if you have any notion, or maybe somebody else does, of why genomic testing is not widely used in Europe. I think we've heard that the Europeans feel that it's not really proven, but at any rate, your answer.
I absolutely don't have an answer to that one, Howard. I could speculate, but I'd rather not. I think even in the U.S., the use of genomic testing has become more prevalent in recent years, and genetic testing is something that is just recently being pushed. And as I said, the NCCN is recommending that for those who are in everywhere from intermediate unfavorable on up. And it's not currently on the recommended for those of us in active surveillance, even though I chose to do that.
Now PCRI, which I think is meeting today, but at a meeting last year, Dr. Klotz spoke, and he said he is trying to encourage some of his patients to undergo at least genetic testing, which is less expensive. But maybe I know the prices for the genomic testing, the germline testing, but can you explain, do you know the prices? Maybe you can tell the audience a little bit about the prices, retail and wholesale through insurance, and whether there's actually a need to undergo so many genomic tests as you've had.
The genomic tests list anywhere from $3,000 to $4,000 US list price. What they tend to do, and what I've been discovering through my direct experience as well as experience with others in a couple of support groups I participate in, is that it's really very negotiable. And if you don't have coverage, you can get by for a relatively small number. And what I mean by that is, when I was originally looking to get the Oncotype DX, they came back and said at that time that the list price was $3,000. The nurse from the facility that I was going to came back and said they're willing to cover everything but maybe a couple of $100. This was from the GPS people who offer the Oncotype DX. In others that I've spoken with, they've been able to get the price down significantly. One individual in one of the groups, because he had no coverage at all and was minimal in the financial aspect, they offered to do his for $100. And this was from the actual company. I think they're interested in gaining the database more than they are in just trying to get the earnings. And of course, they'll take whatever the insurance company will cover. In my case, mine was covered by Medicare. So,
we should point out, we had an attendee at a meeting that we had last week, you and I. The guy was anxious to have the genetic testing, and he put it on his credit card for $2,500.
Right.
And we kind of advised him to go back and negotiate. Now,
yeah, they told him they were giving him half price, but he could have gotten it significantly less.
We have a question here from Kevin Melberger. I'm not sure. I'm guessing, I don't know if Kevin's from Canada or where, but he mentions having undergone the color genetic test, which looks at genes like the BRCA gene. And he spent about $250 for that. And that was something else that Dr. Klotz had pointed out, that he's been urging. Well, and for those who don't know, he's one of the godfathers of the active surveillance approach. And he's up in Toronto. And he said at this Prostate Cancer Research Institute that he's urging some of his patients to undergo the color genetic testing. But he said there's sort of a natural tendency, based on the way the Canadian system is organized. I mean, people are paying for it through their taxes, but they don't necessarily want to reach into their pocket and spend more. And Kevin also asks, and I don't have an answer to this, would a genomic test work with prostate cancer that is benign? I guess it would say that it was benign. What do you think?
That would probably be it. I wouldn't think there's much for it to be compared with, because it is a DNA analysis that's done. And each of the three that I mentioned look at different sets of genes and different sets of DNA analysis. That was why in my case, we did the Oncotype DX on the first biopsy, and we did the Prolaris on the second, to try to get a comparative. And in fact, you can go ahead.
Yeah, I know. I don't want to ignore somebody had raised their hand. Vicky had raised her hand when she was on a little bit earlier. By the way, she said she was the only woman here. And I don't know if some guys are calling in under their wives or girlfriend's name, but I think there's other women here. But Vicky, you had a question.
My question was, I had a very low score, thank goodness. And, because you brought it up, I've been meaning to pull it out for ages to check my score. What's the difference between the Oncotype DX and genomic testing?
The Oncotype DX is a genomic testing as compared to the genetic testing. The genomic testing is looking at the actual tissue that's been retrieved by the biopsy or other procedure, but usually by the biopsy, where the genetic test is usually done by either blood or urine testing, and that's looking for inherited mutations. Okay, so there's a comparative. So what you're talking about on Oncotype DX, Prolaris, and Decipher, they are genomic. They're looking at the actual tissue. And hopefully on your screen, because I have it on mine, there's happens to be, and I'm not going to go into detail on it, but this is the kind of report that you get back showing your results analyzed and produce the statistics. Okay. In my case, is everyone seeing it? Somebody say yes or no.
Can't hear.
I have it up for a share.
I don't see it.
Okay.
And by the way, this is a relevant question to what you may be trying to bring up. Bob Allen up in suburban Toronto was wondering what your Prolaris results were, but I want, maybe you could point out what we've heard before, or I can point it out.
Well,
the context.
You can't see the report, so I'll just read to you what the elements of it are, and then we'll figure out why it's not technically working. Okay, I'm looking at my Oncotype DX report right now, and I have a score of 20. It's 20 out of 100, and what that does is it rates it. It's rated from very low, intermediate to high risk. 20 is rated as low risk. It then statistically provides the analysis of what's the probability of prostate cancer death within 10 years. And based on this particular analysis, it's less than 1%. Metastasis within 10 years, 1%. And the potential of adverse pathology, basically saying something might have gotten missed, could be 21%. And it's shown graphically, which I'm sorry that you can't see, but there's a couple of different analyses there. It also has what they call the pathology endpoints, looking at individualized risk, which are both showing in the 12 to 14% range. All right, I am in the range that Oncotype DX would say is to be considered for active surveillance.
What about Prolaris?
I'm just moving on to Prolaris right now. In Prolaris, my molecular score was 3.5. Okay, the chart, which I'm going to have trouble trying to describe to you what the chart looks like, but it'll actually plot it and show me whether or not I'm in the range to be considered for active surveillance. And it does. It also analyzes METs, the 10-year metastasis risk. And again, that's on the low side. So it's really complementing the report that I got from the Oncotype DX.
Yeah,
And it plots it. You would see a graph, if you could see it, you would see a graph showing it's plotted in the active surveillance range to the left of the chart.
yeah, maybe we can shift a little bit. Wayne Greaves is asking about the micro ultrasound. And again, that may be foreign to a lot of people in the US and also Europe and Canada. Micro ultrasound was invented in Toronto, actually, down the hall from Dr. Klotz. And it originally was a research device used to look at prostates in mice. And it was such amazing ability to visualize that they moved it onto humans. And it's been spreading around. And, you know, maybe Joe, you can give a comparison to MP MRI. Are they complementary, or does one replace the other?
I would say complementary. The procedure for the micro ultrasound is literally ultrasound. They use the ultrasound with a device that's in the same range as the ultrasound that they use when you're doing the biopsy. Physically, it's about a 14-inch long probe, though, but it will cover the entirety of the prostate as best it can be viewed with the ultrasound. And you do get a visual, and it does show up on the screen. It is real time, okay? And in my case, Dr. Coria from Fox Chase, he was able to point me, and I could actually discern, with a little bit of help on his part, I could discern where I could see the outline of the prostate capsule, and I could see the lesion that he identified in the study.
Let me ask you to put it into context. Will this be used in determining whether you have another biopsy?
That's one of the primary purposes for it, is just that, to determine if there is any benefit to be achieved by going to a biopsy, or conversely, avoiding having to go for an unnecessary biopsy.
I have another question from Wayne, which I can answer. Is it covered by insurance? Now, we have people from multiple countries here. And so, you know, you may have to get an answer locally. I mean, it may not even be available locally, but in the United States, it's considered just another flavor of ultrasound, and the Medicare program for the elderly. And that's what we are, folks. We'll cover that.
There's only about five places in the United States that's doing it right now.
So yeah, it's rare around the world, you know, and maybe it's time for us to let Joe off the hook and turn it over to Mark. Although I have a suggestion for him, unless Joe.
And what's your suggestion? Well, Joe, is there, I don't quite, well, actually, I had a question for Joe before we leave him off the hook. So it sounded like Oncotype was probably the most viable for somebody on active surveillance. But as I was listening to you, all of these things we do for levels of comfort, let's say. And so for myself, you know, so I know what my PSA density is, and I know that's less than 0.15. 0.15 is sort of the point that you If you get over 0.15 on your PSA density, then you supposedly get a little bit worried. I know I'm a Gleason 6, and I know that basically with a Gleason 6, as long as I'm a Gleason 6, I'm probably going to have a long and healthy life. I also know that I've had an MRI, and I think it was a PIRAD. Well, once it was a PIRAD 3, and then it went back to a PIRAD 1. I had a couple of them. But there's I'm just wondering how much information we need to reach a level of comfort. But that, let me just say this, that having been said, you and I, Joe, have already spoken of this, and the micro ultrasound. I'm going to be going down to see Dr. Correa on May 4th. But that's in part, it's interesting. I probably wouldn't be going to get that done if I weren't chairman of Active Surveillance Patients International, because in this capacity, I feel some duty to speak knowledgeably about this new procedure, because I think it's a pretty fascinating new procedure.
Mhm.
But for myself, I don't know that I would bother doing it. I mean, I'm 70, almost 72 years old, and I figured I'm not going to die of prostate cancer. So, I'm just wondering out loud at what.
You're still a kid.
I guess.
Well, Mark, if I can interject too, one of the questions I've asked of my doctor, I say, these guidelines talk about, to stop doing PSAs after age 69. And, but there's an exception to the rule. If you've had a biopsy and you've been diagnosed with prostate cancer, they haven't really said when to stop. I asked him, I've been on active surveillance 10 years and I'm 73. And I asked him, when do I get off the train? And he said, from his point of view, as long as you have, a horizon of 10 years more of life, he for one would like to follow you. But I think that, he is starting to back away from the biopsies. So, that's one thing. So
Well, Howard, one of the things that was asked the other night, and you're probably talking around it a little bit, because someone said, well, if you're getting the micro ultrasound, could you also get a biopsy at the same time?
Right.
And yes, you could. Okay. That was not done in my case because there wasn't an indication at this stage of the game that it's necessary. So, and Fox Chase does all transperineal, but it's a matter of, choosing the right at the right time. Okay. And Mark is saying that he's going because he wants to, from an Aspi point of view. And actually, I was under consideration for a different study, and that's how I met Dr. Correa, and that's how I got on the list to get the micro ultrasound, because likewise, I want to be able to talk to it when I go to this group and other support groups, to be able to indicate how it's done, what is, rather than just saying, well, I heard. Well, no, I didn't heard. I was there. I had it done, and I will actually have a more detailed report, coming from it.
Well, but you should maybe mention the fact that we're going to have your doctor, speaking about transperineal as well as micro ultrasound at the ANCAN US2 meeting. What is that, April 7th?
April 7th, 8 p.m. Eastern.
So April is going to be transperineal month for us. Some people are going to get flowers and we're going to get transperineal exams.
Well, coming back to a point that you had made, and again, this comes back to the issue of comfort, anxiety. You mentioned PSA. Now, I actually, up until about 3 years ago, was getting quarterly PSAs, and then I decided, well, am I getting useful information, actionable information? And there's, every time you get a PSA, there's a certain level of concern, sometimes anxiety about it. So I decided I'm going to get them once a year. I decided that. I did. My urologist didn't decide it. But I do plan to continue to get PSAs probably annually, even though the United States Preventive Service Task Force is recommending that after you're age 70, you don't get them anymore. But I'm figuring.
Yeah, but that applies for men who've never been diagnosed.
Yeah, no, and I know that, and so we're a different sort, and so we should. And my recommendation would be that we should continue to get.
But we don't practice medicine here. That's
Well,
just you speaking for yourself.
Thank you for that disclaimer.
But the thing I was going to bring up, there were a lot of in between questions having to do with transperineal, and yes, we're going to cover it at the ANCAN US2 meeting on April 7th, and we're going to have a super panel of experts on April 24th. But in case some people can't make it to those meetings, maybe we should address some of the questions. And one of the big ones that I saw, David mentioned having transperineal, and Phil also did, but it sounds like they had very different experiences, and it makes me wonder if David may have had the old technique. I mean, transperineal was around since the 1930s, and it was replaced by rectal like in the late 1980s when they got these new biopsy guns, and they also got ultrasound for imaging. And so, that's what this new revolution is about, is to do these biopsies through the transperineum. Somebody asked, are the results different? Well, the information about, from a biopsy is similar, but the transperineal gives the doctor easier access to parts of the prostate that are often missed by the transrectal approach.
The apex especially, yep.
Yeah, so there's a difference in that information. There's a difference in whether you need antibiotics. Antibiotics are routinely given with transrectal. They've been shown not to be necessary with transperineal. So there's a whole list of differences. And but meanwhile, we have two guys at the same meeting who both profess to have had transperineal. And
Howard, the other thing, there's a couple of things that you alluded to earlier, but the transperineal, many were done freehand, where the doc actually had to line it up himself and actually do the penetration. Now they use, the Precision Point happens to be the brand name of it. It's device guided. It's like a mini template that's similar to what they use for brachy, and that's tended to improve it. And they also are doing them now in procedure rooms rather than doing them in the OR.
right.
So it's possible, and I'm not trying to speak for David, but it's possible if it was done in the OR that there might have been something with the anesthesia, which also may have compounded his particular situation.
Well, I wonder if David didn't undergo the older procedure.
Mm-hmm.
And I'm going to ask the guy who invented the new one, what the possibilities are. But David, you're good at research. Maybe you can let us know, which of these procedures you had. Did they use the Precision Point or not, or if they did it the old way with the doctor up on a step stool, coming down on you?
Well, my understanding is that they use a grid, little plastic.
Yeah. Well, the old one used the grid too. And it was very similar to that used in radiation therapy. So, and they at any rate, but we're going to have.
Are you saying there's two types of grids?
I'm saying there's at least two different approaches to this, to the same thing that are called transperineal. And because Phil can speak for himself, but he wrote me a note saying that this is totally different than what happened to him.
The original grids that they were using for TP was the grid that they used for Rocky.
Mm-hmm.
Okay, this is a new one where it's a single area, single penetration, and then it's guided from within, or guided in with internally. So there's a bit difference. I think maybe, rather than trying to beat that to death right at the moment, we have two sessions coming up. You've got the ANCAN one, and you've got our session, which will come up, in another couple of weeks. I think that would be.
Meanwhile, David has his homework. He's got to find that out.
Oh, I know he's going to do that. Yeah.
Well, anyway, let's give, in case we missed somebody's question in the chat box, we wanted to reserve a period of time where you could raise your hand. You would go to reactions. You click on reactions, and there at the bottom, you'll see a raised hand. And so we'll give you a couple of minutes here to raise your hand if anybody wants to raise their hand. And then you can ask the question yourself. And while we're waiting, when we close out, if those of you that were participating in this, the panelists and the questioners, if you have a couple minutes, if we could just hang on for a few minutes after the meeting, I'd enjoy that. It would be a helpful time to debrief a little
Vicky
bit.
has her hand up.
Yep, I see that. Go ahead, Vicky.
We can't stop her once she started.
Apparently. Go ahead, Vicky. Unmute yourself. You're
Muted, Vicky.
Are you muted? You might be muted, Vicky. Here, I'll unmute you. Unmute. Ask to unmute. Or maybe I can unmute her.
Well, she's raised her hand again.
Yeah, well, she's got a...
That's her fist she's waving at us.
Yeah, you got to unmute.
Okay. Yeah, I'm on an iPad, but I'm grateful I have it. The question I had was, am I doing active surveillance by the fact that I decided, it was a gut feeling, my quality of my life was so poor on hormonal therapy, I asked my oncologist if I could stop. And he said, yes, you can stop. But obviously I said, Doc, there's no guarantees. The question I have is, being that I'm going to be monitored with blood work every 3 months instead of every 6 months, is that active surveillance?
Well, I would think in a sense that it is, but what we generally talk about is active surveillance.
Pre-treatment.
Yeah, most of us have never had a treatment. They're in the breast cancer and prostate cancer are very analogous, and there's a type of breast cancer that's very similar to the low risk kind of cancer that most of the people attending this meeting have. That's like intraductal breast cancer. They don't treat it, and they're going through the same issues that the men are, because there's a movement amongst the men to redefine what we have, which is typically Gleason 3+3 or Gleason 3+4 favorable. And there's an effort to redefine those cancers, and the Gleason 6 men is non-cancerous, because chances are they will never turn into cancer. It sounds like your situation is different, but yeah, there's lots of other flavors of active surveillance used with other cancers. So in a sense, it's similar, but it's really very different in terms of the reality.
By the way, Vicky, this just occurred to me that Answer Cancer, an excellent organization, has support groups for a host of different cancers. And the other,
Is that ANCAN, Mark?
that's ANCAN, yeah.
I was going before my computer died, but now that I'm back up online, I'm going to go back to ANCAN. It was great.
Yeah, that and the Inspire community. That's an us2 organization. I recommend that for everybody here, by the way. And the Inspire community is an excellent vehicle. You have a question, a very specific question, and you put that in there, and you'll get a whole lot of responses. By the way, Jeff, I saw your comment in the chat box here, and please, if anybody wants to raise their hand, raise their hand. But I'm going to, Jeff, your point too about concern about antibiotics and how that can damage connective tissue, absolutely right on, and even more important perhaps is what it's doing to the microbiome. And once we take that antibiotic and destroy the microbiome, it's not something that restores itself in a week or two. It takes months for the microbiome to get back in shape.
Mark, can I just comment on
Yeah.
what Vicki said for a moment? There are a lot of different features of active surveillance that follow you through even after surgery or after hormone treatment or after radiation. Like you're constantly watching things. So that, you know, before I went on active surveillance formally, while I was on active surveillance, and then practically speaking afterwards, you're still getting regular PSA tests done a lot of time to see how things are happening. And some of the features are the same. I know people that are going through a similar sounding situation to you, Vicki, that they were on ADT and they've decided to go off of it for a while. There's intermittent, so they're constantly having to watch it. So there are some of the features of AS are going to follow through with the rest of the journey as well.
So I
Thank
see,
you.
Eric raised
I
his
see
hand.
Eric has your hand raised. Go ahead, Eric. What was your question?
Yes, perhaps it's more a commentary than a question, because active surveillance in Europe anyway is only as a first treatment. If you have another interventional surgery or radiation, you are monitored, but this is not active surveillance.
Correct.
And we had an issue that we could not find evidence for active surveillance because everyone was doing something slightly different. There was not a good definition. I am a member of the guidelines committee of the European Association of Urology as a patient. So we are looking for this evidence, and that was a real problem. And on the antibiotics from my past, antibiotics in transrectal in Europe is just 1 day. And this can cause no problems for the microbiome. So that should not be an issue because you take it too shortly. And transperineal should not use antibiotics at all. That you can find it, Trexit. I will send it to you, Mark. The article you can distribute it to PDF. It's open source, so everyone can read. It's short and it describes. And some of the things I heard, and this is one of the issues we had in the guidelines committee, as well with MRI, is you can say that the guideline says you should do it, but do all the doctors who are going to do it are trained? Do they know how to do it? And as well for MRI, where we have not enough specialists to read the prostate,
Exactly.
we have not enough doctors who know how to do a correct transperineal. And that might need an intermediate period where they will learn how to do it. And in Europe, in some countries, the radiologist does the biopsies, not a urologist. It depends from country to country who is doing what, but common to all of them is they need to be retrained. You cannot just switch from the backside to the bottom. That doesn't work. Thank you.
Okay, well, so if no one else is raising their hand, this has been, thank you for those thoughts, Eric. And actually, I don't know if you're interested, Eric, but we're going to have a brief meeting afterwards. I'd actually like to invite you for a couple minutes if you wanted to join us.
Mark, I had one comment.
Go ahead, David. Yeah.
If we have time, otherwise I can take this
No,
off.
just
later.
let's have your
Well,
comment.
quickly,
We'll close out. Yeah, that's fine.
There's, I wanted to follow up on what Eric was talking about and make an inquiry about, but I also wanted to let everybody know about antibiotics. You asked me about an anecdotal story, and this is the most significant one. After my second ER visit, the doctor prescribed me an antibiotic. I never had it before. It's called Levaquin. And I became suicidal.
Mm.
And I literally had a friend of mine call me up and he said, you know, how you doing? What's happening? I said, I'm planning my suicide. Just like I'm going off to lunch. I mean, it was just felt so natural for me to kill myself. And it turned out obviously that's one of the side effects of Levaquin is you can get very depressed. But I literally spent about 4 hours actively planning my suicide, and then it began to wear off.
It's a good thing you're not a good planner.
Yeah, I know. And a slow planner. I wanted everybody to know about that. You asked me a funny story. It's kind of funny. Okay, Mark, back over to you.
Mark, one of the comments, and I don't know whether Howard had it or it was whatever, it's very brief, on the micro ultrasound. One of the things that can be now discerned with that as well is intraductal cancer. You can actually see the duct work within the prostate because it's the intensity, instead of going, the standard ultrasound is like 6 or 7 megahertz, and the micro ultrasound is 29 megahertz, and the resolution is dramatically different. So you can see the duct work.
It's actually like a key in a lock. It's just fortuitous,
Wow.
you know, that this piece of research in mice led to this device.
Incredible. Thank you for that.
Well, okay. Again, thank you to the panel, the questioners, to the audience for your good questions. And if you're interested in getting more involved in Active Surveillance Patients International, we welcome that involvement. So just email me or get in touch with us through aspatients.org. And this recording will be up in less than a week. And so please share the recording. And again, the panelists and Eric, if you want to just chat for a couple minutes, I'd welcome that. So thank you all.